Cell kill in the cell cycle. When we talk about chemotherapy, the first thing to understand is that it's not a one-time knockout punch. Each exposure to chemotherapy kills only a fraction of the tumor cells, sometimes as little as 20%, sometimes up to 99%, depending on the drug and dose. That means the treatment must be repeated in cycles over weeks or months to achieve meaningful tumor regression. Eradicating 100% of malignant cells is nearly impossible, but the goal is to shrink the tumor enough that the immune system can destroy what remains. The cells that are actively dividing are the most vulnerable. We call the ratio of dividing to resting cells the growth fraction. Tumors with a high growth fraction tend to respond better to chemotherapy, but non-dividing cells that still retain the potential to divide are more resistant, and this is what makes them so dangerous. The strategy, then, is to deliver chemotherapy in repeated cycles, or to use multiple agents in sequence, so that non-dividing cells are eventually caught as they re-enter division and can be destroyed. All of this ties back to the cell cycle itself, which every cell, normal or malignant, must move through in order to reproduce. Chemotherapy doesn't differentiate between the two. In the G1 phase, RNA and protein synthesis takes place. In the S phase, DNA synthesis occurs. The G2 phase is the pre-mitotic stage, when DNA replication is complete and the mitotic spindle forms. Then comes mitosis, when chromosomes separate and one cell divides into two. Chemotherapy drugs are classified in part by how they act on this cycle. Some are cell cycle specific, meaning they work best in a particular phase. Many of these target the S phase, interfering with DNA and RNA synthesis. Others, like the plant alkaloids, target mitosis by disrupting spindle formation. Still others are cell cycle nonspecific. These drugs act regardless of phase, often causing cumulative damage that eventually leads to cell death. Combination regimens that use both types are common because they maximize cell kill across different stages of growth. From a chemical perspective, chemotherapeutic agents are grouped into categories. Alkylating agents, for example, bind to DNA, RNA, and proteins, impairing their ability to function and replicate. Nitrosoureas act similarly but can cross the blood-brain barrier, making them especially useful in brain cancers. Antimetabolites interfere with the building blocks of DNA and RNA synthesis, disrupting replication. Anti-tumor antibiotics bind directly to DNA, preventing synthesis altogether. Topoisomerase inhibitors, as their name suggests, interfere with the enzymes that normally untangle DNA during replication. Plant alkaloids and taxanes interfere with spindle formation and mitotic division. Hormonal agents manipulate growth in tumors that depend on hormones. Miscellaneous drugs like asparaginase and arsenic trioxide use unique mechanisms to halt cell proliferation. The choice of agent depends on the cancer type, its molecular targets, and the patient's ability to tolerate the expected toxicities. But remember, all of these drugs affect normal cells too, especially those that divide rapidly, such as bone marrow, hair follicles, the GI tract, and reproductive cells. This is why chemotherapy toxicities are widespread. Toxicities and nursing management. Chemotherapy toxicity can be acute or chronic, and because it targets rapidly dividing cells, the effects can appear in virtually any body system. The gastrointestinal system is one of the first to be affected. Nausea and vomiting are among the most common side effects, occurring within hours or even days after treatment. Some patients experience anticipatory nausea just by walking into the clinic. We now understand that this occurs because chemotherapy stimulates neuroreceptors in the vomiting center of the brain, as well as in the GI tract. That's why antiemetic regimens, serotonin blockers, dopamine antagonists, corticosteroids, and others are given preventively. Nurses must educate patients about continuing antiemetic therapy at home, using small, frequent meals, and incorporating complementary methods like relaxation or acupressure when appropriate. Stomatitis and mucositis are also common, as the rapidly dividing cells of the oral and GI epithelium are damaged. These can be extremely painful and can affect nutrition and hydration. Nurses play a key role in early recognition, patient teaching, and preventive oral care. The hematopoietic system is another predictable target. Myelosuppression is the most common dose-limiting toxicity of chemotherapy. This includes leukopenia, neutropenia, anemia, and thrombocytopenia. Blood counts typically nadir 7 to 14 days after treatment, and this is when patients are at highest risk for infection and bleeding. Colony-stimulating factors can be used to shorten neutropenia, erythropoietin can reduce anemia, and IL-11 can support platelet recovery, though toxicities limit its use. Nurses monitor counts closely, teach neutropenic precautions, and reinforce strategies to prevent bleeding. The renal system can also be injured. Agents such as cisplatin and methotrexate are nephrotoxic, while rapid tumor lysis can overwhelm the kidneys with uric acid and electrolytes. Nurses must monitor BUN, creatinine, and electrolytes, ensure hydration, promote frequent voiding, and anticipate the use of protective drugs such as allopurinol or amifostine. Cyclophosphamide and ifosfamide are notorious for causing hemorrhagic cystitis. Aggressive hydration and bladder protection are essential. Cardiotoxicity is a major concern with anthracyclines like doxorubicin, which have a cumulative lifetime dose limit. Ejection fraction monitoring is vital, and nurses must watch for subtle signs of heart failure. Pulmonary toxicity is seen with bleomycin, busulfan, and carmustine, leading to fibrosis and pneumonitis. Again, vigilant nursing assessment and prompt reporting of symptoms like cough or dyspnea are crucial. The reproductive system is also at risk. Many agents cause infertility, premature menopause, or azoospermia. Nurses should discuss fertility preservation options with patients before treatment begins. The neurologic system can suffer from neurotoxicities ranging from metabolic encephalopathy to severe peripheral neuropathies. Vincristine, cisplatin, and oxaliplatin are classic culprits. Nurses must assess sensation, reflexes, and motor function regularly, and patients must be taught to report tingling, numbness, or sensitivity to cold. Cognitive impairment, often called chemo brain, is another common problem. Patients describe difficulty with memory, concentration, multitasking, and organization. Nurses should acknowledge these symptoms, assess for contributing factors like anemia or fatigue, and provide support and strategies such as cognitive training or restorative activities. Fatigue is one of the most distressing and persistent symptoms. It can last months after treatment ends. Nurses help patients explore contributing factors, disease, treatment, sleep disturbances, depression, and encourage interventions like aerobic exercise, nutrition optimization, and energy conservation strategies. Long-term complications must also be considered. These include secondary malignancies, osteoporosis, cardiovascular disease, pulmonary fibrosis, endocrine dysfunction, infertility, and chronic infections. Survivorship care requires continued nursing assessment and patient education well beyond active treatment. Safe administration and nursing responsibilities. Administering chemotherapy safely is a specialized nursing skill. Nurses must be competent in preventing hypersensitivity reactions, recognizing early signs of extravasation, and managing emergencies. Vesicants can cause devastating tissue necrosis if they leak from a vein. For this reason, continuous infusions are given only through central lines. If extravasation is suspected, the infusion must be stopped immediately, and the nurse must follow institutional protocols using antidote kits and proper documentation. Patients and families must be educated about the importance of reporting symptoms during and after infusions. Nurses stress adherence to premedication regimens and teach patients how to recognize allergic or hypersensitivity reactions that may occur even after leaving the infusion center. Nurses handling chemotherapy must also protect themselves. This includes the use of biologic safety cabinets, closed-system transfer devices, double chemotherapy-rated gloves, impermeable gowns, and face and eye protection when appropriate. Hazardous drug waste and contaminated linens must be placed in designated containers, and spill kits must be available at all times. Hand hygiene after removing gloves is essential. Institutions must have policies, procedures, and regular competency training for all staff who prepare, administer, or handle chemotherapy and contaminated waste. Hematopoietic stem cell transplantation, HSCT. HSCT is used for hematologic malignancies, such as leukemia, lymphoma, and myeloma, and sometimes for solid tumors. Stem cells may come from the patient, autologous, a donor, allogeneic, or an identical twin, syngeneic. Conditioning regimens involve high-dose chemotherapy, sometimes with total body irradiation, to eradicate marrow and malignant cells before infusion. Engraftment typically takes 8 to 10 days, and until then, patients are at high risk for infection, have bleeding, and organ toxicity. Complications of HSCT include hepatic sinusoidal obstructive syndrome, graft versus host disease in allogeneic transplants, mucositis, hemorrhagic cystitis, pulmonary injury, tumor lysis syndrome, and infections of every variety. Nurses provide close monitoring, symptom management, blood product support, and infection prevention. Psychosocial support for patients and families is equally important, as this process is physically and emotionally demanding. Donors also require care and support, as they may experience emotional stress and feelings of guilt if the transplant fails. Immunotherapy and targeted therapies. Newer cancer treatments manipulate the immune system or target molecular pathways in cancer cells. Immunotherapies include cytokines, monoclonal antibodies, checkpoint inhibitors, cancer vaccines, and CAR T-cell therapy. These approaches have transformed outcomes for many cancers, but they come with unique toxicities, such as immune-related adverse events affecting skin, gut, lungs, endocrine glands, or other organs. Nurses must be alert to these delayed but potentially life-threatening toxicities, and prompt intervention, often with corticosteroids, is required. Targeted therapies use small molecule drugs like tyrosine kinase inhibitors, EGFR inhibitors, VF inhibitors, multikinase inhibitors, and proteasome inhibitors. These drugs aim at specific receptors or pathways, minimizing damage to normal cells, but still producing toxicities like mucositis, rash, impaired wound healing, hypertension, and myelosuppression. Patient education about adherence, monitoring, and reporting of side effects is central to nursing care. Adherence and home-based therapies. With the rise of oral anti-cancer agents, much of the responsibility for treatment has shifted to patients and families at home. This creates challenges with adherence, especially in the face of financial, social, cognitive, or psychological barriers. Nurses assess for these obstacles, link patients with financial and community resources, provide education in appropriate formats, encourage use of pillboxes and reminders, and maintain follow-up contact through phone or telehealth. Collaboration with pharmacists, social workers, and providers is key to supporting adherence and safety. Complementary and integrative therapies. Many patients turn to complementary approaches such as herbal supplements, acupuncture, massage, or meditation. Some of these can provide comfort and improve quality of life, but others carry risks, especially when combined with conventional therapies. Nurses must ask about complementary practices, provide non-judgmental education, and identify contraindications. For example, certain herbs interfere with drug metabolism, and manipulative therapies may be unsafe for patients with bleeding risk or bone fragility. COVID-19 considerations. The COVID-19 pandemic highlighted the vulnerability of patients with cancer. These patients have higher risks of infection and mortality. Nurses played and continue to play a crucial role in patient education, infection prevention, coordination of care, and emotional support during a time of heightened isolation and risk.